Good morning to you all, and thank you for inviting me, the IHS team, Dr. Kitsiri and Dr. Amal Harsha, and also I was fascinated by the inputs that the University of Surrey gave us from Professor Jivman, and you saw how much, as Dr. Amal Harsha correctly mentioned in the morning, how much research can contribute to the development of the healthcare sector. So I am here to enlighten you about the connected care systems, and I'm fascinated to see these young souls and energetic hearts among us today in this very good morning. So I usually give lectures for medical undergraduates and the postgraduates. So I see you all as our community with allied health and all that. So beginning with that, so I will go into the digital healthcare in kind of I will enlighten you about what is happening in Sri Lanka. I think most of you all have visited the Sri Lankan Health Institute, the hospitals and all of that. So we talk about this connected care in respect to these two scenarios. So we have isolated islands of data, which is very common in our part of the world. And we have this connected or patient-centric care. So this is our aim. So this is the future that we are aiming with digital health, with artificial intelligence, and so much of development in the healthcare sector. So that is our expectations. So more sooner we can reach here, is more better we can contribute to the healthcare system, whatever. So it will be, we say digital health gives you efficiency, effectiveness, quality, and safety. So all of those things can be achieved through this patient-centric and connected care network. Right. So this is, I just put this image in among the very few slides. So this is the usual, patient journey we see in any part of the world, right? So imagine these are few people, maybe a family or may not be a family. So now you can see there's Kamala here and there's a Panduni, that's the baby, right? So Kamala becoming pregnant and giving birth to Sanduni, right? So imagine this is the journey. So even though this is few years plotted here in the x-axis, but imagine now this is like couple of years. So we have from starting from Kamala's womb to on its own. So they have a journey on their own, right? So birth is just an event which is happening in between Kamala and Sanduni. So imagine now someone is the father, right? So well, he has his own burdens of diseases, right? And then, so Somavati and Piyasena, imagine these are their parents, right? So they have owned their lives. So diabetes is a continued disease over time. It may not have started 2025, but more before than that, right? So and Sumanavati, well, she was diagnosed to have lung cancer somewhere in between on Kamala's pregnancy, right? Imagine. So this is the journey. So this can get more complicated than simplified in any context, in any part of the world, in any country, right? You must have seen patients like this. So we can't have individual records of a individual patient without considering the other scenarios, other atmospheres. As Professor Jivman mentioned, there are so many, we say, determinants of health connected to people. We can't take a disease as an individual, instance of thing happening like a bomb blast. It's not like that. It's like the Big Bang, right? So it happens with so many determinants around that. There are, we call cultural determinants, there are economical determinants, there are, biological determinants, our genetic factors, and so many things are there, right? So we can't take diabetes as a disease itself with high glucose levels where we, pick the finger in the morning and get a fasting blood sugar. That's not that, right? How much the person, imagine the PSA can afford to the treatment of diabetes, right? We say, yes, sugar is bad. So what else can he eat? Does he have healthy food? Healthy food is very expensive, right? You can't live on vegetables and proteins and, eggs and meat. It's very cheap to buy a loaf of bread from our, shops or canteens or whatever, right? So that determines, right? So this is the journey. So when we talk about digital health, it's not simple as having a smartphone at our palm or fingertips and connecting the people, right? So these are some of the beneficiaries of connected care system. So beneficiaries, I put this slide to show you that it's not only the patients, right? Patients come, yes, of course, they are the immediate beneficiaries of the healthcare system. Patient who seek care at the healthcare institution, that's the commonest one, right? That's what we see. But there are other ones. So providers during healthcare delivery. So you as allied health practitioners, we as doctors or nurses or so many people, there are so many stakeholders who become beneficiaries, right? Then the public health officials. So we see now there are so many, public health emergencies, the diseases that are happening. Dengue is there are so many communicable diseases, there are pandemics we have faced, right? So they utilize these monitoring, right? Then citizens utilizing health services, the citizens who are not patients, right? They may be, just who are browsing the internet. They may be just referring the news which is posted or, broadcasted, right? So those are citizens. They are beneficial. Then the healthcare administrators, they are one of the, most kind of beneficiaries or stakeholders in these platforms, where they have to utilize their money, their effort, their planning, right, based on evidence-based decisions. That's what research we do, right? So not only clinical research is important, but administrative type of research is also important. That can be easily done through connected care systems. Then the vendors, we can't forget about them. They are the ones who are pumping the money to the systems or developments or certain things, right? So they see new investments, they see new platforms, right? So those are also beneficiaries. So then other developers, there may be software developers, maybe architects, so many things are there. So not only the patients are on the picture. So it's a complete, if you take a complete picture, this list is not complete enough, right? There are so many stakeholders, so they are all involved. Right. So I put this slide. So these are some of the things that So I'm talking about pillars of connected care. So digital health, I put into 3 pillars. The first pillar is the electronic health records. You all know what is an electronic health record is there. So at any stage in your life, or any, your parents, your patient or whatever, whoever have seen these things. So these are very common in any part of the world now, right? So you can have a smartphone and you can download any kind of an app from Apple Store or Play Store, and you can have your own electronic health record. But to have connected care, there should be certain characteristics. So one of that is longitudinal health record. So longitudinal health record means that, as if you can remember that journey, so we have to start from the beginning of our life, at least. So from our birth, for immunization record to, our initial child health development records. So that comes as a longitudinal record. We say womb to the tomb. Well, it will go beyond that also, but at least from womb to the tomb, right? Before you were born, even the record starts. You will not have a name in that record. You know that when a soon baby is born, we call by the name of the mother, baby of Sumanavati or something, right? So from that level, this starts, right? So the electronic health record may not have your name as Gayan, Kasuno, Saman, right? Then interoperability we will talk later. So that simply putting up. So we have to connect every system together, right? Then clinical decision support. There's no point of having a record if it doesn't give some support to us, right? It's not just a Excel sheet that we plot giving the dates on this column or that row or whatever, right? So it should give some support for us. Otherwise, there's no point, right? Then, as I mentioned, efficiency, effectiveness, quality, safety. So these are all, 4 words as a mantra we call in digital health. So that at least it's better to have all 4, but at least few of them are not there. It's pointless to have digital health, right? So if it, increases the burden of the staff that are working on records. Imagine that putting a receptionist to type patient records on a reception desk or something without improving any of these will, burden the system. It's better than to have a paper record or writing some with pens and pencils and have our own bed tickets as our conventional way. If it doesn't improve any of this, right? So that is there. So governance we will talk about later. So all these things should be there in the pillar of electronic health. So these are some of the additional details. I hope that you have heard about the electronic health records comes here. So there are certain other records that we call electronic medical records, which are not connected. So that is the record in a single place of hospital or practice, where usually they are not connected. So and the best one, or we can say gold standard or something, is the personal health record, which is owned by the person or the patient, right? So this is the simplest one we have now. If you take hospital A, we'll have hospital A record, which is not connected to, if the patient goes to hospital B, they can't take their records, something like that, right? So interoperability comes from here to here, where every record is connected. So the next pillar is the telemedicine and remote care. So you all know something about telemedicine. So that's a huge pillar. Yeah. Electronic health records will be in line with this one or incorporated into this one. So, but we talk about universal accessibility and inclusivity. Inclusivity means everybody, a patient who is in Jaffna, Trinco, in Australia, in UK, must be inclusive to have the services, right? So then the clinical equivalence is that it should give somewhat equivalent care that we are giving conventionally, right? If it gives, lower quality kind of care, then it's not good to have a telemedicine platform. Imagine now there's a patient who's having all the facilities, the mobile phone, the connection, the subscription and everything, and he's opting to have telemedicine, but he doesn't get the optimum care. Imagine that's a diabetic patient who doesn't get control of diabetes with telemedicine. It's not of use. It's better to spend some money and traveling to Colombo or whatever and get medicine rather than using telemedicine. It's not social media telemedicine, that you have to have some quality or clinical equivalence. If patient can be living in Jaffna, but he or she should get the equivalence of care in Jaffna using the telemedicine. It's not a fashion to have this digital health. It should give the quality, efficiency and at least the equivalent care what we are conventionally having. Then the ecosystem of integration. So it's as I mentioned, the electronic health record should be integrated into this system. Otherwise, the telemedicine will be in a one kind of platform, then the electronic health record will be another kind of application. It doesn't work well, right? In the privacy and security, and all of these things we have the governance. I will mention that later. Right. So that is the telehealth. Telehealth is the umbrella term. So it has so many things: teleeducation, telemedicine, patient portals, and all that. So it's a kind of an umbrella term. But what we are clinically practicing mainly is the telemedicine. Then the other pillar is other health information systems. There are numerous kind of health information systems which are there. So this is where the interoperability should have. If you can see from the back row, so there are so many platforms, so many things, right? You can see telemedicine here, tracking applications, you have e-channeling applications, right? Diagnostic softwares, then prescribing softwares, right? Remote patient monitoring, pharmacy tools, supply chain management, appointment scheduling, so many information systems work in silos, but if they are connected, that is what we want, right? So these are some of the guiding principles for connected care. So if we divide them into two, kind of categories of principles. So this is the business principle. So everything is a business, right? Not money oriented or, economically focused, but unless you think it as in that aspect, it never develops, right? That's what's happening in our part of the world with free health, like free education and that kind of stuff, right? We are not business oriented most of the time. So unless you have that mind of orientation, you don't evolve. That's the problem, right? So if you have the business principle, so this is, one thing as I mentioned earlier. So it should be patient centered. Now in our conventional system, maybe the consultant or the doctor or the healthcare administrator oriented care is given, right? It's not that so. So we have to have that mind in that our principles, right? In the standardization, I will mention a little bit later. So we think as something that we have to have a common standard in our healthcare, right? Then it should share the information. Then innovation and partnership. Evolutionary change, cost effective. So these unless we have system, I'm not talking about a particular system A, system B, or some kind of a application in part of the world like that. But unless we have these principles in ourselves, in our, working in our mind, we will not be going into the connected care. So this is the technical principles. Yes. Privacy, security. We face so much of, cyber security incidences, events, and, news every day, right? And then interoperability. Then the scalability. Scalability means we have to have some space to develop, to scale up. Then reuse services, open standards, right? So these are some of the technical principles that we expect. Right. This is the governance. So this is called the digital health building blocks, which was published by the government, used as a joint publication. So you can see some of the components that we discussed earlier, but on top of that, there should be some leadership and governance. Unless this is there, it's nothing going to work, because there should be some kind of it's not administration only, but it's oversight. It's some responsibility. It's some guidance, right? So that is the governance. So we have investments, we have services, applications, standards, infrastructure, right? Legislation, workforce, the human resources and all that. And on top of that, we have the governance. Unless we have that, we can't sustain, especially digital health. So this is one of the, guiding milestones in Sri Lankan digital health we are operating, right? So this was published quite some time earlier in 2023. This is called Sri Lanka Digital Health Blueprint. This is what we are hoping to build digital health in Sri Lanka. I don't know whether you have seen this one. So anybody interested, you can refer this link and go to the publication and read about that. So I will talk some of my, slides on this one, which is based on the architecture that we have guided. This is not a system. This is an architecture, a framework, which as a foundation to build. So this is what I was telling from the beginning. So people or patient-centered healthcare is what we expect to build, right? So it has, now this is a brief illustration what some of the systems as you have seen, right? So we have laboratory systems starting from blood tests through any samples, pathology specimens or whatever, right? And then we have our normal bedhead tickets and health records. And we have other, kind of like public health and child welfare clinics and all that, immunization weight, right? So all going into a patient's national electronic health record. So this is the record which is owned by the patient or the person, where he or she has all these components in there with an interactive kind of a connection. So that is the interoperability we are talking about. So this is some of the workflows that are given in that blueprint. If you can see, so these are the point of services. So we have several point of service. This is why the health system is so complex, right? We have providers, we have staff, we have patients, we have the general public, right? So unless these point of services are recognized and connected, we can't give the connected kind of care, right? So they have the point of services, then we have a shared information exchange where they are all connected. So we have several other, platforms that are operating, but it should connect with the point of care with a single data exchange. So this is the interoperability. So interoperability doesn't mean that system A should be with everybody in the country. Yes, we can't do that. We can't have that, right? So as like you are using several bank accounts, we don't have a single bank in Sri Lanka, right? We have several, I don't know how many, maybe 10 or more banks in Sri Lanka, but you can use your same, credit or debit card in any ATM machine and withdraw money. So that is interoperability. You can't go to, if you have a bank and you need not to go to the A bank ATM to withdraw money, because all the ATM machines are connected. So that is the interoperability, right? So healthcare also, you can't go to hospital A and can receive, treatment and get discharged. And next week you go to hospital B, and when you say, yes, I was admitted to hospital A last week, then the hospital B can't say, no, we don't have that records. You have to go there and ask for the printout or something, or give a pen drive or a CD and bring that information to hospital B. So if that is so, That is not digital health and it is not interoperability. Right? It's of no use. Right. So this is I will not go to describe everything. So this is the expansion of this facility. So from point of services, you can see number of things are there. Right. So this is the digital health blueprint. I will not go through each part of this one. So you can refer. I just want to put this thing to, if you have time, read about this one. So this is to identify, you understand how the digital health structure should build on. Right. It's not simple as having a smartphone and downloading app from the Apple Store, Play Store, and thinking that this is digital health. Right. So it's very complicated. So there are several parts that point of services. So many things are there. Right. So we have nutritional management systems, dengue systems are there. Right. Then the lab information systems, these are leprosy information systems, right? Mental health information systems. So many things are there. Cancer control program systems, right? Then logistics, we have hospital management systems called Swasta. We have several systems like HHIMS or hospital health information management systems. Then private hospital systems are there. Cloud-based systems are there, right? So GP systems. So many things. National STD and AIDS control program systems. So there are so many points of services. We can't have, one system to give every services like, every services under one roof or something. That's not the idea of healthcare, right? So healthcare is diverse. It's complicated. Right. So this is the digital health, the exchange. So exchange has so many components, not only the connection. So connection is the API management. So application program interface. And then there are messaging, validations, right? Load balancing, right? Logging. So many functionalities should be there in an exchange. Exchange is kind of like a railway station where so many trains are coming in and going out, but working without any collapses, right? So that is the exchange. Right. So these are some of the details there, which I will not go through everyone because we are running out of time also. So this part is important. That's why I put this one. So security and privacy services. So data security is very important in any part, any application of digitalization, right? So it may not be healthcare, it may be your banking services, it may be your financial services, it may be your, whatever the details, it should be privacy and security. So these days it's extremely important. So there are so many things other than the, encryption and, secure passwords and everything. So there's a thing called, if you can see timekeeping. So imagine now health record, if patient, now I go to hospital A now, but their time stamping is different. Imagine that the clock is not updated, right? So we sometimes see in our computers, the dates are different, right? So if that is stamped in our health record, then I go next time to another hospital, they will say, you were admitted, in 2028 or something, or in the 1990s, right? So even timekeeping is a matter of security. It can be, duplicate records based on timestamps. You can't admit patient on, this instance and then discharge a day before today, right? So that is also security and privacy concerns. So many details are there in this, which I will not go into detail. Right. So this is the interoperability, as I mentioned. So most of the things should be connected. There are so many, all the point of care applications or services should be connected. Right. So this is another, kind of a framework which called OpenHIE architecture. So these are point of services and there's an interoperability layer. So this is like the health exchange. Right. So these things cannot work in isolation and it should be connected to, there are so many registries, if you can see, right? Client registries, facility registries, worker registries, hospital, it may be a doctor, a nurse or a physiotherapist that should be there in their registry. We can't have kind of a foreigner, or a foreigner means that the total stranger treating a patient with a, AI piece of appearance. So unless you have your name in the registry, you can't serve, especially in telemedicine. We don't know who is in the other side of the phone, other side of your screen, who's appearing before. It may be a totally, AI crafted cancer specialist or somebody. We don't know. Maybe named with Dr. So-and-so with so much of qualification and these things. We don't know. It may be a total stranger who's appearing on the other side of the phone. So unless you have a workforce registry, we can't verify that. So imagine so many dangers are there unless this is like uncharted waters where you should sail cautiously. So many dangers. This is where we are dealing with life. Now, if your bank is hacked or you are leaked, you will lose your money. So of course you can earn back sometime, right? But imagine this is your health record being hacked, manipulated. The worst case scenario is it can be altered. Imagine you are having diabetes and your regime of treatment is changed to cancer care. Next time you visit the pharmacy, you will be given cancer medicine, which of course you will die in a couple of days, right? So this is a matter of life and death. So this is the interoperability in digital health. So we can make it into several grades or tiers, right? So macro tier is in between. You can go up to even connecting countries. Well, the UK NHS records can be connected to Australian My Health record, to Sri Lankan digital health or national electronic health record. So that is the macro tier, that level. Or we can discuss hospital A, B, C, D are connected together, right? So that is the macro tier, but in between there can be a meso tier where inside the institute, imagine now this is the hospital IIHS, right? So you have several departments. You have the nursing department, you have the physiotherapy department, you have the laboratory department. All those departments are connected. So that is also a part of interoperability. And then we can have micro systems, so micro tier, where a patient have several other apparatuses and all that things. Here you can see, right? So this is the future of healthcare, right? This is not future, this is already happening, right? So these are several robots who are serving. And there are, wearable devices. If you can see, there are, smart patches, sensors, wearable devices, cameras, right? And even this mat has a smart carpet where it is, embedded with sensors, where these are elderly people who can fall, who can trip or, soil themselves or whatever, right? Their glucose can go out, right? There are motion sensors are there. So this is also connected. This should all be connected. You may be wearing a smart watch, a smart ring, right? Oh, this is the remote caregiver, right? So this is the micro tier. So all should be connected to give quality care. Right. So this is the stages of evaluation. So we should start from here. We should digitize first. Digitize doesn't mean that we are finished with digital health. That's what we think, right? So digitizing means that we digitize certain things. Our workflows need to be digitized. Digitizing the entire, workflow that is existing in the hospital is not digital health, right? We can't digitize all the paper records and make it into a computer-based interface and enter all the things and hope for have this digital evolution. No. First, we have to define, we have to optimize what we can throw out of our workflows and what we should, incorporate or streamline, right? In the capacity building, so many things. Then we can connect people, institutions, facilities, right? Then we share. So sharing is paramount of importance. So we structure communications, applications, and the data. So that is where the standards come in. And then the information. So inform, so we have the repository, we incorporate decision making, then we innovate and transform as our profit. So innovations comes there. So they have a biobank of data in UK NHS, right? So that is, you don't need any new collection of data where they have the data bank, right? So how much applications that we can make from digital health. So I today only learned that the sweet tooths can have depression. So, well, you all can do some research why they are getting depression. Maybe they are not because they are obese or they have the communicable diseases. Maybe so many other factors causing depression because of craving to sugar, right? So that is the innovation. That is the transformation. Transformation is we are now thinking a sweet tooth is coming to your clinic and we never think about depression on that fellow, right? He may have so many, diabetes, hypertension, cholesterol, so many things on that basket, but we never think of depression unless he, come out of blues and like that. So that is the transformation we have. So we charter these waters with, kind of an insight where we transform the patient lives into new insights. That's the thing, right? So this is a standard. So I mentioned there are what comes to our mind when we say standards are there are so many standards. Like, if you take a water bottle, there's a standard in there, like ISO standard or whatever, right? So there are so many standards. So there are terminology standards. Terminology means the vocabularies, the languages we talk English, Sinhala, French, whatever, right? So that kind of thing. So the healthcare, we speak these languages. I don't go into detail. So there are transport standards. So we can't transport a health record to another, that is, hospital A to hospital B. We have to transport that language in a packet where all the, hospital A and the B and also possibly C and D will also understand, right? Then the privacy and security. Then the content standards. So there are so many standards are there. So this is also digital. Right? So this is one standard, Snowmid CT. I don't go into detail. You can browse and learn about these kind of standards. No need to, by heart these everything. But these are some of the standards in digital health. Right? These are transport standards. We call HL7. Higher is the latest standard. So if you are interested, you can read about these things. So these are transport standards. Right. So these are things. I will not go into detail of these things. Right. So this is how the connection. So the reception to doctor, to lab, to other insurance gateways, analytics, notifications, the billing. So many things which are needed in here. These are privacy standards. So UK and the EU has the GDPR. Now the UK is separated. They have their own UK GDPR. And USA have the HIPAA. And these are ISO and the French and German standards are there. And we have this Personal Data Protection Act, right? So if you don't know, read about this thing also coming up. So this is our own privacy and data security, right? So this is also a part of the standards that we have to think about. We have to comply. Now, in UK, they can't do research if it violates UK GDPR. In USA, they can't do research if it violates HIPAA, like that, right? But we do research violating everything. That's something. So implementation challenges, these are final slides I will go into. So you all know. So we are not on the digital health has so many challenges, right? Not only the economical constraints that is very common and anticipatory, but there are technical barriers, infrastructure, connectivity, cultural and social barriers, right? Still, we have a generation which thinks, yes, digital health is useless, right? So we have a generation where probably our mothers and fathers and grandfathers and grandparents, they will think, yes, better to have a paper record than having some record which can go, deleted next time or be hacked by a hacker next time we visit the clinic. Well, those are cultural and social barriers, right? So we have to address that. We can't just, throw out that patients or some people who are resistant to digital health. Then shortage of human resources. We don't have enough skilled workers like you all who are trained in digital health and, have an inspiration on digital health, right? Then the regulatory and policy issues which are coming up with so many improvements now. So these are all, implementation challenges. So this is a kind of a pathway, right? So cost and economy is that's the first step, which we think it's the only step. But now we have staff resistances, time-consuming training is needed, right? Migration data, we have so many paper-based records which are there. We just can't scan them and put into the health record, right? So data migration itself is a challenge. Then lack of usability, limited technical resources, data security. So these are all, kind of challenges we are facing. So if we are in a position to improve digital health in a country, we have to pass all these things to have an electronic health record which is optimized. Yes, so this is the inclusiveness. So we have to include, this is a chain of everything, right? So access to digital infrastructure, skills and literacy. That's what we are doing at IHS. We are improving the skills and the literacy. And inclusive and safe design. So we have to have the design itself to include people, right? Of course, yes, Gen Z, Gen Alpha will be included, but imagine the older generations, your grandparents will not be included unless we design to include them, right? they can't use all of them can't use smart devices, right? So we have to think about something to incorporate. This is the inclusiveness. We can't just, give up on people, certain type of, only Gen Z should have digital health and the older people, yes, you can have all BHTs. No, that is not inclusiveness, right? Then the culturally relevant. So we have to think about that. Yes. We can't just, take some electronic health record in USA or UK and just install it in Sri Lanka and hope that everybody will, download it from the App Store and tomorrow we will have island-wide digital health. No, it's not going to happen. We have to think about these other determinants. That's what I mentioned earlier, the determinants of acceptability, so many things. So culture is one of that, right? And then, yes, not last but the least, this is the regulation. So we should have some regulation about the data, privacy, protection and everything. There should be some responsibility. We can't just collect the data. So every app that you download, you sign an agreement. You just tick, I agree, but there's a few pages of agreement which says in small print that these are the closures, these are the hazards, these are the regulations that we adhere. So that should be there for digital health tools, right? So these are some of the key important inclusiveness, links of the chain which needed for digital health. So that's that. So I hope I didn't exceed my time. So if you have any questions, you can raise any questions from me or our expert panel at any time. And I hope that one day we have a compassionate healthcare worker. So don't forget about your compassionate with these digital devices, right? That is of paramount importance. We become robotized or robotic in front of a digital device and think like this digital health, just you don't have to smile with the patients. No, it's not. You have to have a compassionate healthcare provider, even though we have the best digital health platform in the world. That's it. Thank you very much.